to our webinar on preparing CNA students for the behavioral complexity and unpredictability of dementia care. And I'm thrilled to have Dr. Elizabeth Galik as our speaker today. She is phenomenal. I've done multiple webinars with her and had multiple conversations where she has very much impressed me. So, as you know, I'm Dr. Charlene Brown, the CEO and founder of CNA Simulations, and I welcome you all to our final 2022 webinar. Dr. Elizabeth Galik is chair of the Department of Organizational Systems and Adult Health at the University of Maryland School of Nursing. And I met her 2 years ago, just at the start of the pandemic, through one of my mentors, who's a friend of hers. And I was so deeply impressed by her expertise in dementia. We were part of a webinar series through the Maryland National Capital Home Care Association, where she gave a series of talks on addressing the challenges with taking care of people who live with dementia during the early days of the pandemic. Now she's here today to talk to you as CNA instructors about what are some of the challenges that CNA students will face, or CNAs will face when they enter the workplace, and how you can prepare them for caring for adults with dementia. She's the PI on many, many, many grants that involve dementia and improving function and managing behavioral symptoms. She's past president of the Gerontologic Advanced Practice Nurses Association. She is a scientific review member for the National Institutes on Aging and the International Psychogeriatric Association. She's co-editor, she is now the editor-in-chief of Caring for the Ages and an advisor to CMS. So she brings to the table an immense amount of expertise, and I'm excited for us all to learn from her. And of course, you probably can already tell this, but today's webinar is being recorded. We will share the recording with all of the people who registered for the webinar after the webinar. So it will likely go out either tomorrow or on Monday. And of course, because this is CNA Simulations, I'm going to spend a total of 45 seconds reminding you that instructors love CNA Simulations. Celine Champagne, who's actually on the call, did her thesis on CNA Simulations and found that all of the instructors thought it improved student knowledge and critical thinking. And so this is just an end of year reminder that you can contact us anytime if you'd like to explore using CNA Simulations with your students for the spring semester. And with that, I am going to hand it over to Dr. Galik.
Thanks so much, Charlene, and welcome everybody this afternoon. Thank you for taking time out of your very busy schedules, particularly this time of year, to join us. And I'm excited to be here. I'm going to go ahead and share my screen. And Charlene told you all those things about me, but probably the most important thing that she didn't tell, and actually I'm not even sure if she knows it or not, is I started my career as a nursing assistant. So I worked in the Veterans Administration, the VA in Philadelphia, and that was how I began my career. So CNAs are near and dear to my heart. A lot of my research involves working collaboratively with them to implement interventions, as Charlene mentioned, to improve function and manage behavioral symptoms, particularly in the long-term care setting. So we're going to take the next, I guess, up until the next 55 minutes or so, and I'll go over a variety of things, and then I'm happy to answer questions and have really a discussion at the end and answer anything you would like me to address. So this is really focused on preparing your CNA students for some of the behavioral symptoms that they'll encounter when they're working with older adults with dementia, particularly in long-term care settings. And I have two objectives for today. So one is for you all to be able to describe some of the clinical pearls related to providing quality dementia care that you can use as CNA instructors to implement in your teaching. The second, I'm going to share with you a publicly available problem-solving strategy that you can also use with your CNA students to address and kind of dissect and better understand behavioral symptoms for individuals with dementia. So this is kind of a common scene that we see in the long-term care setting. So here the nursing assistant is going and trying to help a resident with oral care. And, you know, there's the cup, and it looks like there's a denture cup over to the side. And, you know, that individual is trying to provide good quality care, but the individual with dementia doesn't really fully understand. And rather than kind of pushing that cup towards his face, he's giving body language cues about, I need you to back off. I need you to give me some space. And so we're going to talk about some of these things that your students can recognize. We know that a vast majority of individuals with dementia, kind of approaching almost 100%, at some point during the course of their illness will exhibit what we call as behavioral and psychological symptoms of dementia. It's also known kind of as BPSD. And it's a bit of a catch-all term, and it includes a lot of different symptoms. So it can be things like physical and verbal aggression or outbursts. It can be resistiveness or rejection of care, which is kind of what we were seeing, at least in that other slide where he was saying, hold on, I don't really want to do this. It can be psychotic symptoms. So people can have delusions or hallucinations that then drive some of their behavior. We also know that about 2/3 of individuals with dementia experience what we call a clinical apathy. So they don't have kind of the motivation or the executive functioning to plan and organize and begin activities. And so that's why cueing, reminders, guidance is so important with individuals with dementia. We all know that depression is common among individuals with dementia, as well as anxiety. And while less common, really it accounts somewhere between 3 and 5% in general. But individuals with dementia can exhibit some what we would consider to be inappropriate sexual behavior. So a nursing assistant student may have a resident that they're helping with a shower or a bath, and that individual may be aroused and misinterpret that assistance with care as a sexual advance, and then may touch that CNA student inappropriately or make an inappropriate comment. We also have experienced individuals who have kind of repeated or repetitive vocalizations where they're calling out and the staff member goes up to that resident and says, can I help you? Is anything wrong? And they say, no, I'm fine. And then you walk away another minute and the repetitive vocalizations begin again. Insomnia is also quite challenging. So these behavioral and psychological symptoms of dementia are common, and they can really vary person to person, but most individuals with dementia experience them. So the impact of these behavioral symptoms, so for the patients or residents, if we're talking about long-term care, it can negatively impact that individual's quality of life. It also can increase the risk of injury, particularly if they're resistant or trying to get away. It may lead to inappropriate use of some of the psychiatric medications, which can lead to sedation and falls and other adverse drug events. And in many instances, it exacerbates functional decline, because if someone, if a patient with dementia is known to exhibit challenging behavior, staff may be less inclined to spend time with that person. And so they may experience this more rapid functional decline than the disease trajectory would suggest. For caregivers, when they're working with older adults with dementia, with behavioral challenges, it tends to take, they tend to spend a little more time in care of this population because they have to keep kind of maybe going back or reassuring or They may not be able to accomplish a task that they're trying to help the resident with in that one visit, or they may have to change their approach. Staff are also at an increased risk of injury, and in some instances, individuals may not enjoy working with older adults with dementia, which can decrease job satisfaction and may lead to staff turnover. So how can you, as CNA instructors, prepare your students to care for individuals living with dementia? And we're going to talk about kind of my top 10 tips. So this is not really a primer on dementia care, but some of the things that I think in your training, if you can integrate these points, will help your students make a better adjustment in caring for individuals with dementia. So clinical pearl number 1 is really emphasizing with your students the importance of getting to know the individual with dementia. And there's a quote that we've probably heard in a variety of ways. When you've met one person living with dementia, you've met one person living with dementia. That everybody is a unique individual, and you have to acknowledge that. So what worked with Mr. Jones may not work with Mr. Smith in terms of an approach. And while there are some guiding principles that we follow in dementia care, the most important thing is to treat people individually and get to know them as individuals, and try to provide care that is focused, that is person-centered and focused on that person. So this second clinical pearl really kind of goes along with knowing the person, but takes it a little step further. I do some exercises with the CNAs that I work with, and I call it knowing their favorite things, or sometimes I say understanding what makes the residents tick. And that quote actually came from a study that I did with some expert nursing assistants who, it was a qualitative study where they provided feedback about ways that they were able to motivate individuals with dementia to engage in their own care, whether that was functional or physical activities. And then you're not only just knowing this information, but then you're able to apply it to care practices. So some things that are helpful to know are the residents' preferences. So I tend to be a morning person, and my husband is kind of a late night owl. And if I was living in a facility with him, I would be much more cooperative if you helped me with a shower in the morning. And he would be a lot better if you helped him in the evening. So kind of knowing some of these preferences can make a difference in terms of care. The other piece is engaging residents in meaningful activity. Not what's meaningful for the caregiver, but what's person-centered and meaningful for that individual. There's a gentleman that I care for who lives in an assisted living facility, and he was someone who really liked to keep busy and was a volunteer throughout his life after he retired from his work. And so even though he has very severe dementia and pretty significant communication deficits, he can't really speak in a way that most people can understand. He likes to be busy with particular jobs. So they have him help fold the laundry, to go out with the staff once a day to get the mail from the mailbox. And that routine and that meaningful activity makes him feel better. And when he doesn't have that, things are a little more challenging. It's also helpful to understand people's past interests and their past history. Things they like, what kind of employment they had, and then also who are their trusted individuals? Who can we draw upon that would be someone that patient or that resident would trust? We can use some things, it's called simulated presence, actually, where you may get a recording. It could be an audio recording or a video and audio recording where you're having that trusted person, whether it's a daughter, a spouse, whoever it is, or even a nursing assistant that person knows well. speak to that individual with that recording so that if other staff are providing care and that resident is a little resistant, if you can pull out that recording from the daughter that says, "Mom, remember, it's evening time and you need, it's time for brushing your teeth or taking your dentures out before you go to bed." And so that trusted voice or it sometimes can be helpful. It's called simulated presence. Also, understanding what brings residents joy. And I will do an exercise with some of the nursing assistant colleagues that I work with where I get them to talk about their own favorite things that they like, things about themselves. And I say, come up with somewhere between 3 and 5 things that you really like that bring you joy. And then having their partner come up with ways of what they would want to integrate into that person's care plan that would address the things that they bring that brings them joy. So, for example, I'm a big dog lover, and I also love my morning cup of coffee. And if you wanted to get me to do a little more walking, if you promised me a cup of coffee or a dog on the other side of it, or even looking at a picture of an animal, I would be more apt to do that. So you would use that information to motivate. Okay, clinical pearl number 3. So a lot of times you may hear that like a resident has challenging behaviors or is difficult or is aggressive. When that happens, we justifiably kind of get a little on our guard and get nervous. And we may go in with multiple people, or we may go in feeling tense or anxious. Individuals with dementia can sense that. They can sense that unease, and they will mimic back to you the emotion that you are displaying. So even if you're a little nervous, you have to kind of be like an actor or an actress and kind of calm yourself and display that emotion that you want reflected back to you by that patient. Okay. Next is when providing care, particularly with individuals with more severe dementia, you want to avoid too much talk and too much touch. And that's because individuals with more severe dementia have fairly significant receptive aphasia. They may not understand things that you're telling them, and they will get overwhelmed with it. Also, they may misinterpret a touch in terms of care as an assault, and then may either resist or become aggressive. So a good thing to keep in mind that helps to decrease this resistiveness to care is to give the amount of cueing that helps that resident to do as much as they can by themselves, but not talking like I'm talking to you right now, which is just too much information for someone with more severe cognitive impairment. And giving one step or really simple commands. If they can't understand language, have that nursing assistant student role model the behavior that you want them to do. So if it's brushing teeth, mimicking that behavior so that they can see it and follow along, because remember, they're kind of great mimics. And that works a lot better rather than having individuals kind of the caregivers kind of touching that other person to make them do the activity. I also do another exercise with nursing assistants and that you can do rather simply with yours is I get little Dixie cups and just water or something nice to drink. And I have nursing assistants pair up, and I have them give someone something to drink. And then I have them also have that person hold the cup with them guiding it to see how different it feels. And they get that sense of having more control when they're assisting rather than just taking over and doing for someone. And that gives them a little more of kind of that affective learning where they would know what it would feel like to be a patient or a resident. So the other thing I like to to emphasize with nursing assistants is one of my favorite things about working with older adults with dementia is if you try an approach and it doesn't work, in time, these folks forget, usually rather rapidly. And so you almost always get a do-over. You get to go back at another time and try a different approach and see if that will work. So it's fine to be creative and try different approaches, and you can always come back and try something a little bit different. Okay, this next slide in Clinical Pearl really is talking about engaging individuals living with dementia in functional and physical activities as much as possible. So we know probably from our own experience that if you spend a lot of time at your desk or in a chair and you're not moving around very much and not doing very much for yourself, you're going to start to get a little uncomfortable. After this webinar is over, you're going to be seated for about an hour. You're probably going to want to get up and move around. And also, if you're spending much of your day not doing much at all, one, you'll be bored. Second, you're not getting enough exercise, which decreases your muscle mass and can negatively impact your balance. So you'll be more likely to fall. And then lastly, you're going to be less inclined to be sleeping at night if you've not done anything during the day. So anytime you can get someone with dementia to move in whatever capacity that is safe for them, it really makes a difference. The one picture here shows a woman who's kind of using a sweeper. And this is something that's familiar to her. We don't necessarily want her cleaning the place, but this is something that's a familiar activity and makes her feel useful, and she enjoys doing it, and that helps with her balance and keeps her active. We tend to have a lot of groups, particularly in long-term care, where we're doing cognitive stimulation with residents, but maybe not so much physical stimulation. So anytime you can get them involved in something physical, it makes a difference. And this is just an example about we had a contest at a facility where I was consulting, where I gave people pool noodles and balls, and they could come up with different activities that they could do with these things, and they tried them all. We had a contest. So this one was using pool noodles to bat the ball around. Other people use them, I don't have a picture of it, but to do golf games. Some people used it as range of motion exercises, stirring the pot, etc. So it doesn't need to be expensive to get people to move and engage. The next clinical pearl is if a resident is having some type of behavioral symptom, always consider the impact of pain on that person's behavior. When we're in pain, particularly if we have if you would have severe dementia, that individual may not be able to share with us verbally that they're in pain, and instead may be irritable or grumpy or not want to move. So you want to always kind of consider that. There was a study that was done, I guess it was probably about 7 years or so ago, where they took individuals living in nursing homes who had exhibited some type of behavioral symptoms, whether that was physical aggression, verbal aggression, motor restlessness, repetitive vocalizations, etc. And they gave people Tylenol if they hadn't been on it to see if that would help some of their behavior. And what they found is that treating pain didn't really help with the hitting, punching, scratching, biting kinds of behaviors, but it did result in a statistically significant and clinically significant decrease in repetitive vocalizations and motor restlessness, so that people were much more comfortable. So always kind of consider, could this be pain? There is a scale that's available out there that's pretty short that the nursing assistants could even perform if they were trained to do it, called the pain AD. It's just a few observations about the individual with dementia, and it may be suggestive of pain. So things like grimacing or being restless, or a variety of other symptoms. So that's always something to kind of consider. All righty. And clinical pearl number 8, routine and consistency are really important. So individuals with dementia tend to do better when they have consistent caregivers. It doesn't mean that that the nursing assistants can't have a day off, but you get to know those individuals better when you're working with them on a routine basis. You get to understand kind of the rhythms of their day, their likes and dislikes, etc. Tends to be better for the patients as well as better for the staff. And then having some type of structure to the day where you're getting up around the same time, you're doing certain activities that, again, may be meaningful. So having that consistency is really, can really be helpful. That number 9, and this is really an important one, and I think nursing assistants can play a critical role in helping to identify residents who may be acutely ill or have a episode of delirium. So having nursing assistants be able to recognize and report sudden changes in a resident's cognition, level of consciousness, function, and/or behavior. So if the resident acts in a certain way kind of all of the time, and all of a sudden that nursing assistant who spends so much time with the resident is noticing that there's a change, it's important for the nursing assistant to, again, be able to report that to the charge nurse, and trying to be as specific as possible. So oftentimes I would have nursing assistants that I worked with come up to me and say, as a nurse practitioner, can you go see Mr. Elkins? He's not acting like himself. Now, I knew that they would know those residents so well that I would always take them seriously and go look. And I would usually spend time with them asking additional questions. Okay, when you say not acting like himself, what does that mean? What have you noticed? What specifically is different? Is he more sleepy during the day? Has there been a decline in his ability to function? Is he still eating and drinking well? Is he sleeping at night? So trying to get them to be as specific as they can and to advocate on behalf of that resident. Also, it can also be helpful for them to get a set of vital signs, because sometimes what we find out is the resident may have a rapid heartbeat, or they may have a fever, or they may be short of breath. Being able to bring that subjective as well as objective data to the nursing staff can make a difference in terms of the charge nurse acting and taking that issue forward for further evaluation of the resident. And I will tell you, when nursing assistants report this, oftentimes it's either an acute medical illness that they've picked up on, some very subtle changes that they've caught early, or it's a medication side effect that they've identified. And that side effect could just be lethargy and poor appetite, but it could be a result of a medication. Okay. And this is just so important. And I find that the nursing assistants are, when they're working with consistent residents, they're really tuned in to what a normal day is like for them. And if they're starting to notice a trend in a different way, having them have the confidence and the ability to report these changes to either the charge nurse or the treatment team really can help to save someone a trip to the hospital in many instances. And then our last clinical pearl involves medications. So We know that individuals with dementia may have behavioral symptoms that we've talked about. And while there are medications that psychiatric medicines that we may use to treat some of these behaviors, all medicines have risks associated with their use. And many of the psychiatric medicines have particular risks for older adults with dementia. So the antipsychotic medicines, things like quetiapine, its other name is Seroquel, or olanzapine, and its other name is Zyprexa, or risperidone, other name Risperdal. Those types of medicines have an increased risk of death due to acute cardiovascular complications or pneumonia. And so having someone request one of those medicines or other things like it to calm the person down may not be in that resident's best interest. Sometimes we need to use those medicines, but they've really only shown to be effective for people who are a significant risk to themselves or others, or they have identifiable psychotic symptoms that are kind of observable and measurable. For people who call out, just giving them an antipsychotic medicine tends to just sedate the person, and they risk the acute cardiovascular event, stroke, or pneumonia. So understanding that any medicine we give is going to potentially have risks, even beyond the antipsychotics, the mood stabilizing medicines, things like lorazepam or Ativan, all of those medicines can increase the risk of adverse events. And many times it's usually sedation and falls. So we just have to really be careful and try to use, when we can, our non-pharmacologic approaches and not to over-rely on medicines in this particular patient population. Okay, so now we're on to our second objective, where we're going to talk a little bit about the origins and risk factors of behavior problems. And this little diagram here really is showing that when an individual with dementia is exhibiting a change in their behavior, there's different things that could be influencing it or causing it. It could be because of the individual's cognitive status. Perhaps they have severe dementia and have difficulty verbalizing what's wrong with them. They may not tell us, but we may see changes in their behavior. Or they may misinterpret something because of severe dementia. They may see a trash can and kind of interpret that as a place to go to the bathroom, and may use that in an inappropriate fashion. There may be changes in the environment. It could be overstimulating or understimulating that cause changes in behavior. It could be the caregiver approach. So if you're rushing someone, or if you're doing too much for them rather than engaging them in their own care, it may result in increased behavioral problems. And then we also talked about just a little bit ago about how different medications or physical illness, a deterioration of a chronic illness or a new acute illness can result in changes in behavior. And then the last thing we want to consider is a new psychiatric problem, because in many instances, it could be the contributions of all of these other factors. So what that individual with dementia may be trying to communicate to us as care providers is, by their behavior, is, I don't understand you, it's too noisy, you're rushing me, I'm in pain, or I'm sick, or I'm depressed. So there's an approach called the DICE approach, and it's an acronym. It stands for describe, investigate, create, and evaluate. And I find that this particular approach can be quite effective in giving a structure for nursing assistants to report symptoms that they're observing related to behaviors to the treatment team, to the interdisciplinary team, and then it gives them a voice in terms of trying to investigate or think about potential causes. So when they go to report a resident's behavior, they want to talk about what the behavior is. Be specific. Saying someone is agitated is not enough. It could be Mr. Jones throws his drink on his neighbor during meals every night. So that gets at the specific behavior, who's involved, and you could name the other resident's name. The setting always happens in the dining room. Frequency, it's every day, and duration, it's happening at night pretty much every time. So you want to give as specific information as possible and not just rely on non-specific language. Then it's also helpful to get the nursing assistants to do a little problem solving on their own, thinking about and investigating the contribution of, do we think that some of this behavior could be related to that person's cognitive deficits? As I mentioned that example with the trash can earlier, could the environment be too stimulating or understimulating or just not right? Maybe having a noisy dining room in the evening with lots of residents with dementia in there may not be good for one or both of those residents. Could it be the caregiver approach? Or again, we want to consider physical or medical problems and then any psychiatric symptoms. And then they're going to be able to go and report, describe the behavior, and then probably give some preliminary ideas about what they think might be going on to the charge nurse. And then ideally, if it's a good charge nurse, they're going to work with that nursing assistant and the interdisciplinary team to really create a plan with interventions that are personalized and meaningful. So it doesn't just involve putting somebody in an activity program. It really helps to get multiple people involved to try to decipher why the resident's experiencing this change in behavior. And often it's helpful to have the involvement of the interdisciplinary team. And then at the end of it, you don't want to just go forward with a plan and not consider that to evaluate it. So working with the team to decide upon a time frame for reevaluation. And then the nursing assistant's role may be in documenting or at least providing reports as to what they're seeing. Is that behavior changing or not? So what's the target symptom, and are they seeing a change with the plan that's been decided by them and the interdisciplinary team? I've included for you some non-pharmacologic resources that you can feel free to integrate into your training. These resources are all free for use. There's no charge associated with them. Some of them are kind of repositories for informations and handouts. Others include like function focused care, and the UCLA Alzheimer's and Dementia Care videos include short video vignettes that help to address some either care activities or challenging behaviors that individuals with dementia experience, and how you can kind of go about providing a better care approach. And then last, I'm going to give a shameless plug for Caring for the Ages, which is a news magazine that's freely available to the public. And it's sponsored by the Society for Post-Acute and Long-Term Care Medicine. I provided the link to it. It's freely available online, and we publish 8 issues a year. There's also a companion podcast called Caring on the Go, where we talk about some of the key articles in the issue. And a new column that we have for 2023 is Nursing Assistants Corner. And it's an interview done by a writer, but it's information provided by a nursing assistant with advice and education for nursing assistants. And feel free, there's different ways you can kind of follow what's going on in caring in our various social media platforms. So we'd really like to kind of try to get some of this content out. And again, it's freely available to you and your students. So I'm going to stop sharing for the moment and pull up the chat. and see if I can see any questions here. And it looks like we have a lot of people from Texas. That's great. I'm coming to Texas in January to go to the Cotton Bowl. All righty.
Does anyone have questions for Dr. Galik? Thank you, by the way, that was amazing. I felt like I was just absorbing and learning every moment. Yeah, so I'm gonna give you.
So Julie, I think you have your physical hand
Yeah.
up. Go ahead.
Yeah, I do. Do you have any creative ideas as far as like the DICE approach? Because this is actually the first time that I've heard of the DICE approach, that we could as instructors like implement in the classroom to give like our students a better, I guess, learning path, and you know, what they can do as nurse aides with patients who have dementia.
Sure. So the way that I implement the DICE approach, if I'm doing it in a classroom setting, I usually have a case study that I present with a patient or a resident who's having some behavior problem. And then I tell the nursing assistants that I'm working with that they need to now act as reporters and detectives. So they have to be able to report what they're seeing and what their findings are. And sometimes I'll have them practice with me or with a partner, as if the partner, do a little role play, as if the partner is the charge nurse. And I'll usually kind of say to the whoever's playing the part of the charge nurse, if you feel that you haven't gotten enough information to act on it, just say, oh, thank you for telling me that, I'll check into it, but don't seem engaged, and see what that person can do to kind of come back and give more information.
Okay.
So that's one way you can use the case study approach. If you're providing education kind of on a unit, whether it's in the hospital or a long-term care facility, we will often, I will ask the staff, who is a resident that's exhibiting some behaviors that the staff find challenging? And we'll work with that resident and as a group kind of do that DICE approach together. So it can be in real time with a real patient, or it can be done in a case study approach. You can also, some of the videos that I shared with you, you can use some of those videos as an example of what behavior would be, and then stop it at certain points and say, okay, how would you describe that behavior? You know, when is it happening? What more do you need to know? And then what, you know, let's investigate the different contributors of that person's dementia. You know, can that person communicate verbally or not? You know, does the person look ill or sick? So kind of going through that process. So there's a variety of ways that you can utilize the DICE approach. It's basically, they call it DICE, but it's basically the nursing process or the engineering process. It's just a problem-solving approach. But DICE is something that usually most people can remember.
Okay, thank you.
Sure, Celine?
Celine, do you know that you're on mute?
How about now?
Now you're good.
Okay. Pearl number 8, you said that routine and consistency are important, and it's having the same caregiver. How do you handle it when students come in for a couple of hours once or twice a week? That isn't consistency, but we want our students to learn how to work with residents with dementia.
So what I usually do is, if I'm changing their assignment so that they get different experiences, I will try to keep one person the same, so they get to build on that relationship. So like if you have to have them work, you know, let's say they need experience with somebody with a catheter looking at the, you know, you may rotate them through different residents, but I try to at least keep 1 or 2 residents the same so that they can see that pattern over time. Does that make sense?
It does for the students learning how to watch for that consistency, but how does that affect the resident who needs that consistency?
So I think that in our lives, we all have people who we work with consistently, live with, whatever, be friends with. And then there's also individuals that kind of come in and out of our lives. And I think if, as a resident with dementia, if everybody was coming in and out of our lives and we didn't have any consistent behavior, that would be a big challenge. But sometimes the nursing assistant students, the CNA students, can be kind of one of those refreshing new people or new experiences, as long as there's at least a staff member or a family member or something like that who's consistent with that person. The other way that you can teach about the importance of consistency is to get that student to talk with the nursing assistant who usually cares for that resident and kind of say, I'm, assigned to caring for, Mrs. Jones today, and I know that you normally care for her. Can you tell me some of the things that you found helpful in getting her up in the morning and providing AM care? Does she have any preferences? Like one that's common is some residents with dementia don't like closed in spaces. So when you take them into the bathroom, and if it's small, they don't like it and they may try to leave. And that person may do so much better sitting in their room with their toothbrush and oral care things and other stuff brought to them, where it's more open rather than kind of in that space. So if one of the students is having challenges, getting them to draw upon the experience of that person who has that consistent relationship can be helpful.
Thank you. That's helpful.
Yep. And just because care and consistency is important doesn't mean that a little excitement once in a while is a bad thing. Something new and different. We talk about the importance of past life experiences, but I've also seen residents who maybe have never done something before in their life develop a new interest or something they like to be engaged in. So it's kind of that balancing. A little bit of the old, but a little variety once in a while will tend to not hurt people too much. Any other questions?
Celine has her hand up again.
I'm sorry, I couldn't hear.
I think Celine has her hand up, or the little yellow hand.
There we go. Anybody else? You can unmute yourself or raise your hand or type it in the chat. Yep, Julie.
I have a question for you, just out of curiosity, because you travel to like different nursing facilities throughout the states. Have you seen a change in like staff CNA's approaches to people who have dementia? Have you seen like a change in like their compassion towards the residents?
So I think what I've seen is not so much a change in terms of people's compassion, but for staff who have been out there a long time and have really lived through the past 3 years, I think we're going on 3 years now with the pandemic, there's just a little bit of an emotional overload. And they're tired. They're tired, and they can be a little burned out from time to time. And so really thinking about strategies of giving people breaks, how to not just hire new people where you're relying on your tried and true employees to train and retrain people over and over again, but also focusing on retention. I think the industry, particularly long-term care, could do better about career opportunities to recognize the expertise of CNAs. So in other words, not all CNAs want to go and become an LPN or an RN, or some do, and that's great, but not everybody wants to do that. I've worked with wonderful CNAs who say, I don't want to do that. I just want to be a CNA, but I want to be recognized for my years of experience and the good care that I provide. So having, career opportunities for them to mentor and get paid more, those individuals who might be new to the field, so that their expertise is really recognized. So I don't, and I think the staffing shortages have hit a lot of places. I've kind of seen that all over, and it's been a challenging past 3 years. And we know with pandemics that, like, while the worst of things may be over in 2 to 3 years, there's ongoing bumps that happen for about 7. And, I just think we're kind of in a tough place, but we really need to value our CNA colleagues. And I think those of us in leadership positions within, and I speak mostly from post-acute long-term care, but in those settings, need to acknowledge the important work that they do and not hide behind computer screens and do virtual visits when the staff that are providing care are there day after day. So,
Right.
being engaged, setting an example, being a role model, listening to the staff, all of those things are important.
Okay, thank you.
You're welcome. And then I think we have Liliana has her hand raised.
Yes, let me see if I can share. Hi.
Hi.
Hi, everybody. Hi, thank you. My name is Liliana. I'm from California, but originally from Mexico. And I am very happy that you took the opportunity to teach us. This is very important. So I just finished my CNA certification, actually. And the approach that you take on your class is pretty much what I do with my private client. So I did take the CNA class because I'm already a caregiver. So, but what you said about the lack of recognition is what hit me, because what the nurses can do without CNAs. So of course the money matters to all of us, and I can see it. Sometimes you are very I guess being more empathetic is what we need to do, so with our colleagues. So, but thank you so much. So I'm very, very happy that I joined this. I know everybody, they're teachers, so I was the only one that was a student. So, and I can see from my approach and my experience that all of this, what you said, it really helped us.
Thank you, Liliana, for your thoughts and wonderful comments. We also have Jennifer DeRose Barger, who says our local Department of Aging offers simulation lessons related to changes in senses that people with dementia or older adults are experiencing. And they have students perform tasks while wearing garden gloves and glasses. I know I've seen sometimes they put Vaseline on the glasses that are just to make it difficult to see through. They also put headphones in with loud noises, or they muffle people's hearing so they can't hear well. And that affective learning or that personal experience the students get is very heartfelt. So you can check with your local area on aging. Sometimes they have similar activities. And in Maryland, I know we have a group that does that training throughout the state.
We did, at the school, we have a training actually focused on dementia.
Mhm.
They applied the Pearls program, which was very interesting. And it's also something that I like to apply with my private client too. So I guess being the focus here is being more empathetic with the patient. So
Mhm.
like that, you're gonna be able to understand what their feelings are on the situation.
Yep.
So thank you so much for everything.
Thank you all. It was a pleasure to get to be with you. I'm on the East Coast in Baltimore, so it's the afternoon here. So thank you all so much. And thank you, Charlene, for inviting me.
Thank you for joining us. We have one final comment. Actually, there are a lot of comments basically saying, Dr. Galik is amazing. Your insight is wonderful. I agree. This was awesome. And I will be sharing this information with my, CNA instructor. Like all of this feedback just for you, like the information you shared was so specifically relevant to this audience and so useful. And I can already tell that instructors are going to be applying it in how they teach. And so thank you for joining us and helping to shape dementia preparation for CNA students around the country.
It's my pleasure. I've been at this a long time, and I hope you can tell I really enjoy it. So
Well, we enjoy having you. For everyone who's on the call, we will send out the recording and a summary, a recap of the webinar. Our incredible intern Benjamin is on the call, and he's been furiously taking notes. And so once the webinar recap and the recording are available, we'll send it out either tomorrow or most likely next week.
yeah, and Charlene, make sure Benjamin includes the links to the things I put in there, because that will give you a whole host of other resources that you can integrate into your teaching.
Absolutely. All right, let's give Dr. Galik a round of electronic clapping. And thank you all for joining us today. It was a pleasure. Yes, exactly.
All right. Happy holidays, everybody.
Happy holidays, everyone. Bye-bye.
Take care. Bye-bye.